Let's do anatomy. A probe placed in the esophagus for transesophageal echo, that is TEE. Transesophageal echo at the level of T7, T8 thoracic vertebra, that is between them. Which heart chamber lies proximal to the probe and it sees first? Okay. In transesophageal echo, if this is the esophagus, the probe is placed here and it looks like this at the chest wall, and heart is in the way. So that's how we see the echo images of the heart. So which chamber does it encounter first? That is the question. Answer for this question would be left atrium. I'll show you why. This is the cross-sectional image of thorax at the level of T78 vertebra. At this level, okay, T78 vertebra. So this is the aorta, this is the aorta, this is the sagus vein, this is the esophagus. If the probe is placed here and it looks like this, the first chamber encountered is left atrium. Okay, this is left ventricle, this is right ventricle, this is right atrium. Right ventricle is always anterior, you know that. Okay, and left atrium is posterior. Anatomical understanding of the heart chambers and its positions is important to answer this question. Posterior communicating artery aneurysm most commonly affects which cranial nerve? Answer is oculomotor. If I show you the images, you will understand. So, in the undersurface of the brain, you can notice this area that is shown here. So, this is the middle cerebral artery arising from the internal carotid. This is the posterior cerebral artery, and both are connected by posterior communicating artery. What lies adjacent to it is cranial nerve 3, which is oculomotor nerve. So if there is an aneurysm arising, this is a huge aneurysm, and then the oculomotor nerve is getting impinged. That is what asked here. Even in a small aneurysm, the oculomotor nerve is impinged and produces symptoms. And one additional point is that pupillary symptoms comes first. Okay, once those symptoms arise, you have to always evaluate for an aneurysm or its rupture because it is an emergency. What is the what is the anatomical structure relating to the marked area? This is the marked area. So the anatomical structure is jejunum. See, this image is very important because it has been asked many times. All right, it's very important. So please study this image. I'll show you. So this is the small intestine area for jejunum area, and this is for the colon area. All right, and this is for the liver, this is for the spleen, and this is for the stomach, and this is for the duodenum. Okay, once you start to see this image once or twice, you will remember this. This has been asked several times, so please study this. Okay, and muscle attachments to femur and humerus, tibia are important questions. This was the marked question. This is the lesser trochanter. The important structure, that is the important muscle which is attaching to this part, is iliopsoas. Don't need to study everything, just see what I am telling. So iliopsoas is here, it is attaching to the lesser trochanter. All right, and then also note the gluteus minimus in the greater trochanter. Okay, and obturator internus, and that is not that important, but gluteus minimus is important. And also in the tibia, note the iliotibial tract attaching this portion, lateral part of the anterior surface, and then in fibula only biceps femoris, this is getting attached. Note that. And note that semitendinosus is attaching to the posterior aspect. And also I will show you the iliopsoas here. And gluteus medius is attaching to, this is the question, FMGE question. Gluteus medius is attaching to the greater trochanter. You can see 4 minutes. Only this is enough. Don't get confused by all the other parts. Just see these. It will be enough, I think. Okay. Taste sensation to anterior two-third of tongue. Okay, sensory supply to the tongue is a bit complicated, so I'll just write it out for you. So first, you need to understand there are two senses carried by the tongue. One is taste, another is touch, the simple touch. That is general sensation. They call it as GS. This one is a special sense, right? So you have to know what is supplying the anterior two-third, what is supplying the posterior two-third, what is supplying the posterior most part. So in the anterior two-third, taste is supplied by chorda tympani. Touch is supplied by lingual nerve. Posterior two-third is supplied by glossopharyngeal. Posterior most is supplied by vagus. 10th cranial nerve, internal laryngeal nerve. Okay, this is same for both taste and touch, these two. But here there is a difference. Taste is supplied by chorda tympani, which is a branch of cranial nerve 7. Here cranial nerve 7 and 5, mandibular nerve to be exact. Okay, so here the question asked was taste sensation anterior to third, so answer would be chorda tympani. Okay, marked structure. See, cadaveric images have been increasing in frequency in the examinations, so that's why I have included all the questions which I have asked as cadavers. Okay, you may find it hard or you may find it easy, but don't there is always a simple answer. Okay, so in this you have to identify like what is the structure marked, right? So first we will see the brachial plexus and then it will be easy. So initially there are roots first, okay, and then there are trunk, and then there are division, and then cord, and then branches, right? This is how we study. So we can see root here. These are the roots, and then the roots are joining to provide trunk, upper trunk, middle trunk, lower trunk, and then they divide into anterior and posterior. Two anterior of the upper trunk join to form the lateral cord. All the posterior divisions form the posterior cord. The lower trunk's anterior division forms the medial cord. This is how the brachial plexus is being formed. Okay, so in this knowledge, if we can see the cadaver image, we can see that these are the roots, right? These are the roots, and we can see the roots are forming the trunks at this level, upper, middle, and lower, and then they start to give divisions. Anterior division 2 is forming the lateral cord, and anterior division of the lower trunk is forming the medial cord. All the posterior division 1, 2, 3 are forming the posterior cord. Okay, so the answer for this question would be posterior cord. And then it further forms various nerves. This is the median nerve, and then this posterior medial cord continues and it forms the ulnar nerve. Okay, and what else I can show you? This is the pectoralis minor muscle, and then this is the brachial artery. Okay, so cadaveric images may seem like Greek and Latin initially when you see, but look at the options. This one, if you look at the brachial plexus, okay, this one is very medial, this one is lateral. So obviously you can rule out medial cord. Okay, something is in middle. So you can differentiate between middle trunk and posterior cord simply by the level. It is roots are here, trunk could be somewhere around here. With that itself, you can mark. It is the with the options. Cadaveric questions are very easy. Don't get too demotivated when you see cadaveric image. It is easy only. Okay, accessory duct of Santorini in pancreas is formed by. So in pancreas there are two ducts, right? So the primary duct is, that is the main duct, is the virsam, okay, and the secondary or the accessory duct is the Santorini. So what forms the accessory duct of Santorini? The primary duct of so basically there are dorsal pancreatic bud or and the ventral pancreatic bud. Okay, in the dorsal pancreatic bud, we can split it as proximal and distal portion. The distal portion of the dorsal pancreatic bud and the ventral pancreatic bud, both of these, the ducts of these parts, form the virsang. And this proximal dorsal pancreatic bud forms the Santorini. I will show you an image. Wait. So the answer is proximal part of dorsal pancreatic duct. See, when the pancreas is formed, this is the gut tube. Okay, this is the gut tube. So the pancreatic bud is formed. First, a small ventral part and a bigger dorsal part will form, and the small ventral part will start to rotate along with the duct when the duodenum is rotating. When it rotates, the dorsal pancreatic bud will absorb the ventral pancreatic bud. Okay, and when it fuses, it forms the duct like this. This is the distal portion of the dorsal pancreatic duct, and this is the ventral pancreatic duct. Both of these unite to form the duct of Wirsung, the main duct. And the proximal part of the dorsal bud forms the accessory duct of Santorini. This one is dorsal, this one is ventral. So Santorini is formed by proximal part of dorsal. In case there is a pathology that is it doesn't unite properly, that is called as pancreas divisum. Disregard this image for now. As of now, just note that the proximal part of dorsal pancreatic duct forms the accessory duct of Santorini. Okay, this is again a cadaveric image. So what are these structures? Can you see? This one is the corpus callosum. This is the lateral ventricles. Okay, and what is this? This one is the caudate. Okay, what is this one? This one, putamen. And these one are the globus pallidus, basal ganglia. Okay, what is this one? This one is the thalamus. Okay, I'll clear and show you once again. This one, corpus callosum, lateral ventricles, thalamus. This is the lenticulate nucleus. If we see separately, this is the putamen and globus pallidus. Okay, and this one, right? This is the claustrum. Okay, claustrum. They may ask you claustrum. Study this one properly. And below the thalamus, the marked portion is there. So obviously, it is hypothalamus. Okay. What is the joint marked here? So here we can see the joint marked is pubic symphysis, right? It is a secondary cartilaginous joint. They move very little, right? What is a primary cartilaginous joint? A primary cartilaginous joint example is the first sternocostal joint. What is a fibrous joint? Sutures. Sutures in the head, the cranium, sorry. Synovial joint, we know, knee, hip, etc. So the secondary cartilaginous joints always lies in the midline. Okay, and they move a bit, slightly mobile. This is immovable. The joints question are asked every exam, at least one joint question. So please read it properly. Thank you. Physiology. Prolactin hormone level increases in which phase of sleep? So before we go to the answer, prolactin is a pituitary hormone, and we will see what is a sleep cycle. Sleep cycle is 90 minutes. There are two types of sleep, REM, NREM. NREM had 4 stages, 1, 2, 3, 4, but now the nomenclature has been changed, N1, N2, N3, and that's it. 3 and 4 constitutes N3. So basically NREM has slow waves of sleep while REM has fast waves, that is beta waves. Here there is delta waves. Beta waves is the waves which is produced during the wakefulness, that is when you are awake, beta waves are produced. This wakefulness is present in a sleep time, so our body may move. So in order to prevent the moving during the REM sleep, what our body does is to deactivate all the muscles. How it does it deactivate? Causes atonia of all muscles except diaphragm and eye muscles, that is extraocular eye muscles. This is because of this extraocular eye muscle exception, that is it does not undergo atonia, eye moves rapidly, that's why it is called as REM sleep. So just remember the important points: REM sleep, beta waves, all muscles undergo atonia. NREM sleep, delta waves, 4 or 3 stages based on the questions they ask. And all the events happen during NREM sleep only, such as sleep talking, sleepwalking, which is somnambulism, and then teeth grinding in sleep. You would have seen your friends do that. And then urinating during sleep, and then having night terrors, except nightmares. Nightmares happen in REM sleep. Okay, all these are NREM, non-REM nightmares. One other important thing is narcolepsy. That is, the patient will suddenly fall asleep without any control. That is narcolepsy. They go into a phase of REM only. Now cardiac muscle feature. Choose a feature. So for the question which we asked, prolactin hormone increases during REM sleep. And during NREM stage 3 and 4, growth hormone increases. Okay, so this is the answer. Next question. Cardiac muscle, what is the feature? The feature of cardiac muscle in this question is calcium induced calcium release. Cardiac muscle has several great features to it. First feature is it has gap junctions. That is a commonly asked questions, and they ask where is the gap junction located. You answer intercalated disc. Okay, and then in the gap junction there is communication happening between two cells, two cardiac cells. There is a communication happening in the gap junction. Because of this, the cardiac muscle can synchronize itself and beat as a single unit. Okay, and to get the power of cardiac myocyte fully, we use calcium induced calcium release by developed sarcoplasmic reticulum. That is, they are very advanced, they can give a lot of calcium at the same time. So that is how we have CICR, which is calcium induced calcium release. And the other option, titin, is present here, it is not absent. That's why we are ruling this option out. Titin is present in cardiac muscle. These two options, A and C, it is true for smooth muscle cells, that is the muscles present in our intestines, etc. They are myosin based. And latch bridge phenomenon. Latch bridge phenomenon means, what is latch? Latch means the lock which we use in the doors. No, we use it to lock our houses. So it means the muscles are getting locked. So the muscles can give prolonged contraction. By this prolonged contraction, what can happen is the muscle can stay contracted or the muscle can stay relaxed for a long period of time. So this is called as latch bridge phenomenon. By latch bridge phenomenon, the smooth muscles can stay a long time. So cardiac muscle feature here, answer is CICR, calcium induced calcium release. And another important point in cardiac muscle is Frank-Starling law. It is very simple law, but it is important. They keep asking. That is, if the length of the cardiac muscle cells, that is cardiomyocyte, increases, pressure also increases. How? Because the if let's say the cardiac muscle is this much, but now it has increased this much, so the inside volume will get increased. So the heart filling will get increased. Because of this filling gets increased, the total amount of blood in the heart is increased, and also the muscles are longer now and it contracts violently, that is, it contracts forcefully. So a large amount of blood and a forceful contraction, both these factors unite and give a bigger output, that is bigger stroke volume. This is leading to the increased pressure. This is known as Frank-Starling law. But there is a catch. This Frank-Starling law is true only when there is physiological limit. Beyond that, it fails. Beyond that, pressure will fall. Even if the cardiomyocyte increases in size, it will fall. Okay, so here the answer is calcium induced calcium release. Okay, this is a cardiac cycle. So first see the options. This question has come several times. So let's see the options. Two valves, aortic valve, mitral valve, and two types closed opening. So one of this is answer. All four are here, A, B, C, D. But which one is C is the question. So C is here. So first we have to know the graph. So from C, what happens? This proceeds in this direction. You have to know that. So from C, the graph proceeds this way. That is, volume decreases. That means in the heart, volume decreases. So if heart volume is decreasing, so the heart is losing volume. That means heart is giving blood. Heart can give blood only to two places. One is lungs, another is body. To give to lungs, which valve should open? Pulmonic valve should open. And to give to body, aortic valve should open. So here, opening of aortic valve is the answer. So this could be confusing. So let's see fully. So when the volume is, see, this is volume, x-axis is volume. So if the graph is moving this way, it means volume is increasing. If the graph is moving this way, it means pressure is increasing. See here, pressure is there. So what does IVC mean? Isovolumetric contraction. That is, pressure is increasing because of contraction. Pressure is increasing because of contraction, but volume is staying constant. That is why volume is constant at this level around 125. Volume is constant, but pressure is increasing from 20s to almost hundreds or 80 something. It is increasing. This is isovolumic contraction. So this is here, mitral valve is opening, so pressure is volume is increasing, pressure is not changing much. Here heart is contracting, so pressure is increasing, but volume is constant. Here aortic valve is opening, blood is going into the body from the heart, so volume is decreasing rapidly. Here aortic valve is closing, and then the incoming blood is just getting stored. The incoming blood, there is no incoming blood at this point because mitral valve is still closed at this stage. So here the volume has left, but the heart relaxes. The heart slowly relaxes without change in volume. No change in volume, the heart relaxes. Again mitral valve open and the heart starts to fill up. So this is how cardiac cycle works. Just revise this diagram once. It has come previously in exams. It is hard to understand by simple explanation. You have to sit and learn yourself. This is a vigorous diagram. This is not very important, but you have to know it. So the primary stuff to know is it has integrated everything we know about the heart and its measurements in a single graph. Just revise it once. It is also integrating the cardiac cycle. Just learn it once. So JVP waveform, I'm not going to explain fully. What is A, what is C, what is V in a JVP waveform? That is what is importantly asked. The main confusing point is atrial contraction. There will be an option. There is an option called atrial contraction. There is one option called ventricular contraction. Which one is, here we will see there is A here, there is C here, there is V in this option. So which should I mark? You will get very confused. So that's why I included this image. So A is atrial contraction. Remember this. C is ventricular contraction. Okay. A is atrial contraction. C is ventricular contraction. And what is V? V is filling. When the atrial is filling, at that time it happens. So do not get confused. A is atrial contraction, C is ventricular contraction. If you remember this, most of the questions you can crack in JVP waveform. nomenclature questions. And then this is on a respiratory system. What is the anatomic dead space and which generation it is? So anatomic dead space generation answer is till 16th. Okay, present till 16th. Why is it so? But till 16th. Okay, so till 16th it is anatomical dead space. Why is it so? Because till 16th there is no air exchange. There is no air exchange. No exchange. Okay, beyond 16, that is from 17 to 23, the air exchange happens. So that's why this is an anatomic dead space or a conducting airway, whatever they call it. And alveolar sac is only 23rd generation, don't forget that. And then 17th, 18th, 19th generation is respiratory bronchial. These are important questions which have been tested previously. Alveolar sac, respiratory bronchial, both are important. And still 16th is dead space. A biphasic response to the GFR change. This is offered by constriction of efferent arteriole. In an efferent arteriole, when there is constriction happening via angiotensin 3, initially GFR increases. This is because when it becomes small, blood gets trapped here and more water is filtered out. Therefore, GFR is increased. But later, after the water is all filled out and the solutes all accumulate in this region, at that time the oncotic pressure compensates and the GFR decreases. This is the biphasic response offered by the efferent arteriole. And one more important point is that ACE inhibitors act in the efferent arteriole by inhibiting the angiotensin 3, and this leads to blood pressure control. Therefore, it is used in the antihypertension medications. False option regarding pineal gland. So let's see one by one. Glial-like cells are seen in this gland. It's true. Two cells are seen in pineal gland. One is pinealocytes. Another one is glial-like cells. Second option, melatonin is synthesized and stored in vesicles in pineal gland. Yes, melatonin is synthesized, true, but it is stored? No. Melatonin is not stored in pineal gland. Melatonin is not stored because it is immediately released into blood after synthesis. Therefore, this is wrong. And then it is a CVO. Yes, it is a CVO. It lies outside the blood-brain barrier. That is the definition of CVO. And then derived from the cells located in the roof of third ventricle. Yes, this is true. Pineal gland is found exactly above in the roof of third ventricle. Therefore, this is also true. So, answer here would be option B. And this is the synthesis of melatonin. Just remember two things. Tryptophan is used to synthesize melatonin, and the rate limiting enzyme is ANAT. It is a catchy name, so I just thought it would be nice to tell you. Next question, Renshaw cell inhibition. Renshaw cell inhibition, the answer is feedback inhibition. I will explain what is a Renshaw cell inhibition. So in the spinal cord, the upper motor neuron comes from brain and it acts on the anterior horns. That is anterior horn cell, which is the lower motor neuron. From there, the lower motor neuron, which is a type of A alpha fiber, goes to the muscles and causes the action. To maintain a control over this action, what happens is this lower motor neuron gives a collateral to the cell called Renshaw cell. This Renshaw cell in turn actually inhibits the original lower motor neuron. That is, even though it gets a collateral from the lower motor neuron, the Renshaw cell inhibits the lower motor neuron. This puts a feedback inhibition. Therefore, there is a control established on the lower motor neuron. This explains further. Therefore, the answer is feedback inhibition. Now, mechanoreceptor stimulated by fast vibration. So, fast vibration. What would be the answer? So, there are 4 mechanoreceptors. There is Pacinian corpuscle and Meissner's corpuscle, which are primarily regarded for the vibrations. But Meissner's corpuscle is slow vibration. And Paxinian corpuscle is fast vibration. What about Ruffini ending? Stretch. What about Merkel's disc? Touch. Braille, which is the blind people used to read now, that thing is mainly associated with Merkel's disc. And also remember the location. In the epidermis, Merkel's disc is seen. The Ruffini and Paxinian corpuscles are seen in the dermis. Where is the Meissner's corpuscle present? Dermal papilla. One more diagram I will show. Meissner's corpuscle seen in the dermal papilla. Paxinian seen in the dermis. Ruffini is also seen in the dermis. Merkel is seen in the epidermis itself. Okay. And free nerve endings is for pain. Okay. Let's do biochemistry. Patients suffering from familial defect in ApoB100 have significantly elevated levels of plasma LDLs. Major reason behind this. Okay. What is the role of ApoB100 in an LDL? It forms the receptor binding domain. That is, it forms the receptors. So this helps in the LDL entering the liver. Let me show you an image. So here we can see LDL and we can also see the B100 receptor. Using this only, the LDL will enter the liver, but because the receptor has ApoB100 ligand. Okay, so the answer would be option A only, not. So the answer would be option A. It does not activate lipoprotein lipase. Cholesterol transfer protein is seen in HDL pathway, and failed to stimulate endocytosis. The end point it could be correct, but the best answer would be option A, because ApoE is also there to stimulate endocytosis. So the perfect answer will be option A. This is a bit confusing, but the perfect answer is option A. And what is this disease called? This is familial, that is ApoB100 defect. Hypercholesterolemia type 2A. The metabolite excreted in urine in thiamine deficiency. What is thiamine? Vitamin B1. Vitamin B1 is seen in aleuron layer of rice. That is the outer layer. Aleuron layer of rice and other grains also. So it has an important role along with the enzyme pyruvate dehydrogenase, which converts pyruvate to acetyl-CoA. So in case this goes into defect, then this goes into defect and this goes to increase. So that's why pyruvate is seen in urine. That's the answer. So what are the diseases seen in B1 deficiency? One is beriberi, which can be wet or dry. Wet is seen in CVS symptoms such as edema. Dry beriberi is seen in CNS symptoms. Okay. And what about Wernicke-Korsakoff? That is seen in alcoholic psychosis symptoms. That is due to thiamine deficiency only. Have to treat it with multivitamin drips. What is the marker for B1 deficiency? It is transketolase. Okay. A 3-month-old infant develops diarrhea and abdominal discomfort following a milk formula. However, feeding history revealed that he was able to tolerate breastfeeding and the same milk formula at birth. The most likely condition is. So at 3 months he is having some symptoms following a milk formula, but at birth it was normal. So this initially rules out milk allergy. We can immediately rule out milk allergy, and this is a primary defect. So primary defect means from birth the defect has to be present and symptoms has to be present from birth. So we can rule this one out also. So we have to see lactose malabsorption, secondary lactose intolerance. So malabsorption may be due to some other secondary disease such as villi atrophy or some other diseases. But here we have symptom of diarrhea. What happens is during diarrhea, the enzyme lactase gets washed out. This leads to lactose intolerance and unable to tolerate the breastfeeding. So therefore the answer would be secondary lactose intolerance. Due to diarrhea, the patient had lactose intolerance. So this is secondary lactose intolerance. Next, an infant with genetic deficiency of glucose 6-phosphatase. Okay, we can immediately identify this as Vaughan-Jarecke disease. Vaughan-Jarecke disease will exhibit this clinical sign. Okay, so we have to study the glycogen storage disease a bit extensively because the exam has got a bit clinical. So poor exercise intolerance is seen in two glycogen storage diseases. One is McArdle, another is Tarui, which is number 5 and number 7. All right, and then glycogen with few branch points. Such question will be mostly related to 3 and 4, which is Corey and Rasan. Here, this one is Corey. The given option is Corey. And muscle dystrophy is not seen in any glycogen storage disorders mostly because it is a part of that Duchenne, Becker's, that spectrum, not related to GSDs. And then finally, hypoglycemia, lactic acidemia, we can diagnose with ruling out also. But to summarize one GRK symptoms, they have chubby cheeks, but thin limbs. They have hepatomegaly and renomegaly, but spleen is paired. Okay. They have a protuberant abdomen. And the enzyme defective is glucose 6 phosphatase. Okay. Which one of the following is not a source of oxygen radicals? Okay. So here we can mark the answer directly because superoxide dismutase is an antioxidant enzyme. It cannot produce oxygen radical. The question is not. So it cannot produce oxygen radicals. I will show you the reaction. So here superoxide is there. It is converted into hydrogen peroxide. So answer would be superoxide dismutase. All these three, superoxide dismutase, glutathione peroxidase, and catalase, all these three are antioxidant enzymes. So the question is exactly opposite. All these three produce free radicals and cause oxidant injury to the body. Activation of macrophage produces because it uses it to kill, and then a transition of metal ions produces in the transporter, and then beta carotene with oxygen also produces oxygen free radicals. Okay. People with bronchial asthma usually have hyperactive airway bronchoconstriction because of inflammation. Which of the following eicosanoid is responsible for this? Direct question. Leukotriene is responsible in asthma for causing bronchoconstriction. They are the most potent bronchoconstrictors available in the body. So we use some drugs to protect asthma patients from asthma by leukotriene receptor antagonists. They are cis-ALT1 antagonists. Those drugs are montelukast, zafirlukast, etc. And then we can also use 5-LOX inhibitors, which inhibit the leukotriene production itself. That drug is zilverton. Next question. Which of the organelles the catabolism of heme for all heme proteins occur? Okay, so when we see the options, we can see mitochondrial matrix, microsomes, Golgi, and cytosol. In both mitochondrial matrix and cytosol, three things happen. Hug. One is heme synthesis, then urea pathways, and gluconeogenesis. These three happens in both mitochondrial matrix and cytosol. But the question is catabolism of heme. Catabolism of heme happens in microsomes. That is where the degradation of proteins occur, right? So answer would be microsomes. Tricky question. Okay. Enzymes involved in porphyria cutanea tarda. Direct question, one-liner, very simple. If you have studied, you would have marked. Simple. Answer is uroporphyrinogen decarboxylase. So it's very important. Acute intermittent porphyria questions and other porphyria questions are asked very frequently. Every time they have been asked, study all these enzymes, and the question is here. Porphyria cutanea tarda enzyme is uroporphyrinogen decarboxylase. Also, just have an overview of this table and other porphyrias. They are asked and tested very frequently.